Pediatric ophthalmology. Pediatric ophthalmology is probably one of the most challenging fields within ophtho, mainly because kids are really hard to examine. I mean, they're really hard. Just checking a vision can be a real trial with kids. Fortunately, with children, if there is something wrong with the eye, there's usually only one thing wrong with the eye, and that can simplify our exam. But I wanted to cover a couple different topics in this lecture. One of them was vision and refraction. Ocular alignments, that's cross-eyed and wall-eyed. Amblyopia, a very important topic in this field. The white pupil and some of the dangerous diagnoses associated. And finally, retinopathy of prematurity. So let's go ahead and get started. Checking vision. Now, obviously, if you have a young child, there's no way to do the traditional vision check. Kids can't read letters. If they're too young, they have very poor attention span. So basically, if you look at this as a sort of a strata of things to check, if with a very young kid, the best you may get is blink to light. A baby, if you shine a bright light in the eye, they ought to close their eyes. When they get a little bit older and they start tracking things, you want to see if the eyes fix and follow, and you want to do that with each eye. As the kid gets older, you can check for pictures. Can they read the pictures on the wall? And finally, you get to the letters. But you know what? The important thing is not so much how one eye does. Can a kid see 20/20 or not with their with pictures? It really doesn't matter. What matters is symmetry between the eyes. As long as both eyes seeing about the same and the vision seems reasonable, then the vision's okay. Now, checking vision in a kid is very hard. So you come up with little tricks, and this is a couple of mine. You need objects, something to attract their attention, and a little toy, a sticker, something, and kids lose attention very quickly. So you have to constantly switch objects. They like cell phones, so certainly cell phones are good. Stickers, anything you can do to get these kids to pay attention. Do whatever it takes. But the important point here is this. Kids are cheaters. You ask a kid to cover one eye and read something on the wall, they're going to cheat. They're going to try to look with their other eye, especially if they have an eye that doesn't see well. So you really got to watch them closely. But checking vision can be a real difficulty. Now, if you think checking vision's hard, how about checking a kid for glasses? If you have a 2-year-old that doesn't talk, how are you going to do it? You can't have them say what's clear number 1 or number 2 on the phoropter. It just isn't going to work. There are a couple of tricks you can try, though. One is the Bruckner test. If you dilate a kid and you shine a light using the direct scope and look at their red reflex, by looking at the reflection, the crescents, what part lights up in the pupil, you can sometimes estimate what their prescription is. For example, if you have an inferior crescent like this, that usually means that they're nearsighted or myopic. Superior, if it's on top, means that they're hyperopic or farsighted. If you see a large difference in the brightness between the eyes, one eye is kind of dull and one eye looks very bright, then you've got to start thinking about some type of ocular misalignment. That bright eye might be pointing off in the wrong direction, and that's why it looks so much brighter. So the Bruckner test, in reality, I don't use this test because if I'm concerned about hyperopia, myopia, etc., I go on and do retinoscopy. So what is retinoscopy? This is a very hard skill to learn. I mean, this is hard. First year ophtho residents are terrible at it. Second year, you're getting better. By the time you're a third year resident, hopefully you're quite good at it. Very useful skill, but the idea is you're using a light and shooting light into the eyes to get an idea of what the reflection looks like in order to estimate glasses prescription. Very useful in people who can't talk, maybe demented patients, and certainly in young children who are pre-verbal. So this is the machine we use. This is called a retinoscope, and a retinoscope is basically just a light, a little beam splitter inside of it that you look through, and you shine this light in your patient's eyes, and you look at the red reflex and how that red reflex moves in order to get an idea of what the prescription is. So here's the theory behind it. Now this is an eye, and if you shine a light into an eye that is in perfect focus, i.e. is not nearsighted, is not farsighted, the light will hit the back of the retina at a single point, hopefully the macula, and the reflection will come back out of the eye, and you can move that light up and down or whatever you want to do, the reflection stays stationary. Maybe that doesn't make sense, so let's try a different eye. This eye is not strong enough. When you shoot light into the eye, it wants to focus behind the eye. And as you move your light up and down, the reflection bouncing off the retina also moves up and down because it's kind of pivoting way behind the eye. So move your light source up and down, the reflection coming off the retina also moves up and down. So we add a lens on here, a little bit of strength, a little bit of power, not quite strong enough yet. As you move your light up and down, once again, the retina reflex is going in the same direction as your light source. So you make a bigger lens, and now the eye is in perfect focus as you go up and down. It hits that single point, and you have the perfect red eye, or the perfect red reflex. If you put too much power in front of this lens, let's say you hold up a really strong magnifying glass like this, then things want to focus into the middle of the eye, right here in the middle of the vitreous cavity, and your reflection coming off the retina is going in the opposite direction. It's kind of pivoting. There's a seesaw action, and you've gone too far. So using this theory, by holding different lenses in front of the eye, you can play around with the reflection as you move light up and down and hopefully figure out a prescription this way. So, what does this look like? Now here's our light. As you pass in front of the eye, you can see that red reflex back there is the line that you're seeing in the background. It's inside the eye, and it looks a lot like the light source, and it goes in the same direction. So we know things aren't in focus. And it doesn't matter what direction you move your light. In this case, it's always going in the same direction. So that's what we call with movement. So let's hold up a +1 lens, add a little bit of power, and the light, the reflex is still going in the same direction. So we're not quite there yet. You notice that the red reflex, that line back there, looks a little bit thicker than it did before. So it's gotten a little bit bigger, but we still have with motion. Not quite what we want. So that's at a +2. That light's still going with, so it's not quite there yet, but you notice that that red reflex has gotten bigger. So we're getting somewhere. Something's happening. We're getting closer to our ideal, perfectly focused situation. So let's try +3. This is it. You notice that the whole eye lights up as soon as that light gets over the pupil. This is the perfect focus, and this is the right prescription for this eye. If you go too far, add too much power, then it focuses in the middle of the eye, and you get that seesaw, that against motion. So if you've gone to against, you've gone too far. So in this case, a +3.00 lens was the right prescription for this eye to get it in perfect focus. Now there's a little bit of a correction factor depending upon your working distance, but this is how we figure out prescription in young kids. So you have a 18-month-old kid. You're trying to figure out if they are nearsighted or farsighted. This is how you do it. You hold up lenses in front of them. This is a rack of lenses, the kind that we'd use on a kid. And you basically just keep up holding up these lenses in front of the eye and checking that red reflex until you get exactly what you want. If you have an adult, you can use a lens rack like this, a retinoscopy bar. This is nice in adults because you don't have to constantly switch lenses in order to find the right one. Doesn't work well in kids because kids don't like having this big giant thing in front of their face. They're constantly wanting to grab it. So with kids, you end up using loose lenses. So retinoscopy, an incredibly difficult skill to pick up, but very useful with both pediatrics and with adults. Alright, next topic, ocular misalignment. If the eyes aren't aligned properly, then you might have an exo deviation. Exo just means outwards, or an eso deviation. That's inwards. There's also a hyper and a hypo, up and down. So let's give a couple examples of this. Let's say you have normal eyes, and one of the ways you can actually estimate if a young child has an eye that's turning in or turning out is by using the Hirschberg test. The idea is you shine a light at the eyes and you look at the light reflex, the corneal reflex of that light bouncing off the eye, and you compare its position to the underlying pupil. And normally that reflex ought to be laying right on top of that pupil. However, if you have one eye that's deviated, for example, this left eye is turned inwards, it's a left esotropia, then you can see that the light reflex is not quite over the pupil like it's supposed to be. In this case, the right hypertropia, the right eye is up a little bit, and you can actually estimate the amount of deviation. And the rule is for every millimeter that this light is off center, so in this case, if this was 1 millimeter off of the pupil, equals about 7 degrees of misalignment or 15 prism diopters, and this is the measurement that we actually use in clinic, prism diopters. So we'll go over prisms in a second, but the Hirschberg test, very useful. Now, we just talked about eso, exo, tropias, phorias. What does that mean? Well, tropia is when the eyes are always deviated. So if you have an exotropia, that means that the eyes are deviated out, they're wall-eyed, and they're always deviated. A phoria, on the other hand, just means that they're only deviated sometimes. So, example of a tropia would be exotropia or esotropia, and of course the hyper and hypo. And of course for the phorias, we would call it something like an exophoria, an esophoria, etc., etc. So let's show an example of this. This eye looks like this left eye is deviated outwards, and we'll use our paddle to cover the eye. This is called the cover-uncover test, and you look for this eye movement, and that tells you that it's there all the time. So no eye movement here, because it looks like the right eye is the dominant eye. This is a left exotropia. So let's try to correct it. And to do that, we use prisms to try to get things back in alignment. Oh, things are still moving, so this isn't quite enough prism to get things back in alignment. Let's try 20 diopters, and now when you do our cover-uncover test, we can see that things are back in alignment. This was a left exotropia, approximately 20 degrees, 20 prism diopters that is. And you pick tropias up with the cover-uncover test, which is what we just did. So let's try this one. These eyes look like they're in reasonably good alignment. So let's do our cover-uncover test. Oh, no movement. Things are still nice and stable. Let's try the other eye. Cover, uncover. Things are still in perfect alignment. Wonderful. But watch this. We'll do a cover and we'll do a cross-cover test. Look at that eye move. Oh, it's moving again. Oh, that one's moving. This is what we call phoria. It's there some of the time, basically when we break fusion. And let's see if we can get rid of this phoria. Yep, about 10 diopters. A prism is all it took to fix this phoria. So this was an exophoria. It's there only some of the time, and there was about 10 prism diopters of it. And you pick up phorias with the cross-cover test, completely different than the cover-uncover test. Okay. So this is a loose prism, and certainly with kids, loose prisms are the way to go. They also make prism bars. Basically put a bunch of prisms in a single bar, and you just dial this thing up and down until you find the right amount of prism to correct. I personally hate these bars. I like to use the loose lens prisms. They're a lot easier to use. My own personal preference. Certainly with children, you want to use the loose lenses because they're smaller. If you use something this big, kids are going to try to grab it. It's not going to work well. And if you have a tropia that can't be corrected by correcting with glasses or patching, then you can always go to surgery. And basically when we have eyes out of alignment, we get them back in alignment. And we do that by either shortening or lengthening the rectus muscles. In this case, this rectus muscle is cut off from its insertion, and it's reinserted back onto the sclera using suture, and this basically lengthens the effective length of this muscle and gets things back in alignment. And you can do the opposite. You can also shorten a muscle and reattach it back to its original insertion. And not an easy surgery to do, because you can imagine you're trying to do a scleral pass here and not perforate into the eye and hit the retina, and the sclera is very, very thin. I mean, so thin we're talking about a third of a millimeter right underneath this muscle insertion. You can very easily perforate into the eye, and not an easy surgery, but very effective though. So that was ocular misalignment. Let's move on. Amblyopia. Amblyopia is very common. I've certainly seen studies saying that maybe up to 2% of the population has some degree of amblyopia. All amblyopia is vision loss without obvious organic cause. Here's the theory behind it. Kids, their brains are still forming until about age 6 or 7. And the wiring from both of the eyes travels through the brain. A third of the brain is devoted to the visual pathway, all the way back to the occipital cortex. This process is plastic. It changes over time. Kids are flexible. It's amazing. Now, if both eyes are working, everything forms fine. But what if you have one eye that doesn't see as well? Well, as the wiring is forming, the better eye starts to develop connections much stronger, and the weak eye doesn't develop those connections in the brain nearly as strong. In some ways, the eyes are competing with each other, at least on the brain scale. So, how do you treat this? You penalize the good eye. You force that, quote, lazy eye to work. That way the wiring can form into the back of the brain, and so that lazy eye can see into the future. Kids can develop amblyopia very easily if they have one eye that doesn't see well. They might have a congenital cataract. They might have one eye that's very nearsighted compared to the other eye, or farsighted. One eye may turn inwards, and so in order to keep from getting double vision, they learn to use one eye and ignore the other one. A lazy eye can easily develop into amblyopia, and if that wiring doesn't form properly, or you don't force it to form properly, you can fix the eye all you want in the future, but the eye will never see that well because the wiring never quite formed right. So amblyopia, important to pick up and treat the underlying cause and force that lazy eye to work by using patching in the other eye. Okay, next topic, leukocoria, the white pupil. All pediatricians do basically well baby exams, and one of the things they look for is to make sure that they have a good red reflex when shining a light into the eyes. The reason why is because if they have a white pupil, there are a lot of pathology inside the eye that can leave a kid blind, seeing poorly, or even there's some dangerous tumors that can happen in the eye that if they're not picked up is a big deal. So the big ones I'm going to talk about are cataract, retinoblastoma, retinopathy of prematurity, and I won't cover really retinal disorders, but certainly anything in the retina can cause a white pupil. So, first one, congenital cataracts. Kids can be born with cataracts. There's a lot of insults, the torch infections, lots of things can cause a cataract, and a cataract in a kid is a big deal, especially if you get it in one eye. A cataract is incredibly amblyogenic. A kid will develop amblyopia very, very fast. So what do? You have a kid who's got a cataract, especially if it's in one eye, you need to take that cataract out soon. So they take cataracts out at 2 months sometimes. I mean, you really can take these things out very early. Unfortunately, kids have a lot of inflammatory response and their eye is still growing, so you take a cataract out, it's hard to put an implant back in because it may be the wrong size, the prescription's changing, inflammation, etc., etc. Most of the time, these kids end up getting a very strong contact lens that the parents have to put in to keep the kid from developing amblyopia. So it's not a good situation, but congenital cataract's kind of a big deal. Here's the other thing, retinoblastoma. Not very common. Basically, retinoblastoma is a blastoma of the retina. It's a tumor that forms from the retinal cells, the photoreceptors specifically, and it develops a white mass that can fill up the inside of the eye and can create a apparently white pupil because you look in the eye and you see this big white thing. Retinoblastoma, I think there's only 400 or 500 a year picked up in the U.S. Not very common, but it's not something you want to miss, because if this retinoblastoma tracks down the optic nerve, hits the CNS, hits the brain, the rest of the body, it could kill the child. So this is something that we dilate, we look for anytime you have a white pupil. Important diagnosis. Retinopathy of prematurity. This is kind of a big topic and an important one, especially if you work in a neonatal ICU setting. When the eye develops in the neonate or the fetus, the retina forms very early. The retinal cells, the photoreceptors, the rods, the cones, the underlying support structure, etc., the retina forms very, very early. However, while the retina itself forms very early, the blood supply that supplies that retina does not. In fact, at about 16 weeks, the blood vessels that are going to be traveling through this retina start to form at the optic nerve. They spread out in all directions to cover the retina. And 8 months, you pretty much hit over here nasally, but there's still a big area temporally that hasn't been vascularized yet. But by 9 to 10 months, the kid is born, and when they are born, their blood supply is ready to go. So, what happens if you have a kid who is born too early, many, many months early, premature? Well, what will happen is the kid is born, and the way I like to think about this is that the retina is already formed. All of a sudden, you throw a kid into a very hypoxic environment outside of the womb, and their eye has to start working, the retina has to start working, but wait a second, the retina's not quite ready to work yet. It doesn't have its blood supply yet. So what will happen is you have large areas of the retina that are forced to work, but they don't have a good blood supply, so they become ischemic, they become hungry. And when this area gets hungry, just like in diabetic retinopathy, it starts to produce molecules, VEGF, endothelial growth factors that promote blood vessel growth, which sounds like a great idea. If you have an area of the body that's hungry, lots of blood vessels sounds like a great idea. The problem inside the eye is that new blood vessels will form, and those blood vessels are completely abnormal. They grow in the wrong place. In fact, they grow along a little ridge along this little borderline here, and those blood vessels can contract, they can scar, they can easily cause a retinal detachment. This is a very similar process to diabetic retinopathy, except in diabetes, it's ischemia from leaky blood vessels from diabetic damage. Here it's ischemia because you're forcing that eye to work, that retina to work, before it's ready, before its blood supply is even formed yet. So, big deal. How do you treat it? Just like with diabetic retinopathy, you use laser. The idea is you ablate with laser, with thousands of little spots out here in this peripheral retina. You ablate all that hungry retina so that it stops producing those angiogenic molecules. It cools the eye down and hopefully keeps it from progressing into a retinal detachment. So retinopathy of prematurity can cause a white pupil entirely because it turns into a retinal detachment, and a retinal detachment looks white. It gives you a white pupil. So, yeah, there's a connection there somewhere. Who do you screen? Well, you don't screen all babies for retinopathy of prematurity because an eye exam and a newborn is quite traumatic. You can see here a speculum you put in the eye. It looks like a torture device. I mean, parents really freak out when you put these in the eye. Of course, we numb it up, but kids can desat. I mean, you don't want to do this in every baby. You want to screen the right kids. And the people, or the children who are found to have the biggest problems, are those ones less than 32 weeks of estimated gestational age, less than 1,500 kilograms, which is pretty darn small, and certainly other risk factors, lots of use of supplemental oxygen, hypoxemia, etc. These are the ones that get screened, and eye doctors are commonly in the neonatal ICU to see these kids. All right, we've covered a lot of topics. Hopefully this was helpful. In summary, retinoscopy, that's the way we estimate prescription and nonverbal children, sometimes in adults if they can't talk. Tropias, that's when you have an alignment problem that's always there. A Phoria is only there some of the times. Amblyopia, the wiring is still forming in the eye. You got to make that lazy eye work before, say, age 5 or 6. Otherwise, the wiring never quite forms and they have vision problems for the rest of their life. The white pupil, important to pick up. There's some dangerous pathology like retinoblastoma. And finally, ROP, retinopathy of prematurity. The underlying mechanism is you make the retina work too early before its blood supply is formed, and that causes problems. All right, so if you want to learn more about pediatric ophthalmology or the rest of ophthalmology in general, please visit me at Ophthobook.com, where you can actually download the individual chapters that go to this book, including the pediatric chapter, and you can also watch the other videos that correspond to the other chapters. So pretty much everything is there. And of course, if you download the PDF of the pediatric chapter, it's a much higher quality. You can read this thing online, but I think the PDFs look a lot better. But thanks for watching.